Perfect. So I do have a bunch of things I want to cover related to psilocybin therapy for depression. I'm going to probably fly through some of the preliminary stuff and hope that many of you know it. We could always come back during the Q&A, try to get to the good meat here. So just brief disclosures, I'm employed by Yale and the Department of Veteran Affairs. I have salary support from the Sona Institute, and I'm lead therapist in their study site at Yale. And the study that I'm talking about today was funded through the Hefter Research Institute. And just a little about my personal background, so you get a sense of where I'm coming from. I do have a background in medical anthropology at a master's level, and was really focused on global health before getting into the psychedelics field. I find there's a lot of overlap between these fields, including really integrating social science perspectives and critical views of health and illness, and trying to translate across different domains of knowledge, from biomedical knowledge to more anthropological and social science types of knowledge. And from my time in medical anthropology and global health, I always had an interest in traditional healing methods, in ethnobotany and shamanism. And so it sort of made a natural fit coming into psychedelic science. I also have always had an orientation towards social justice, and that continues to become ever more relevant in this field. And I'll try to touch on some of the ethical issues that we're facing in the field at the end of the talk. And just personally, I have an interest in Buddhist philosophy and meditation, as well as traditional and ceremonial uses of psychedelic plants. And the work that I am doing focuses on treatment models, which I'll discuss today. And I also have an interest in policy, education, and training in this field. So let's jump in. I've been focusing my research on major depression. Not going to spend time on this other than to say it's extremely prevalent condition, and there's a huge need to just create new treatments. I've been focusing on psilocybin. It's a classical psychedelic, meaning it's primarily a 5-HT2A or serotonin 2A agonist. It naturally occurs in psilocybe mushroom species, which are widespread around the globe. As many of you know, there's a very long historical record of ceremonial and religious use of psilocybin mushrooms. And on the bottom there's a figure on the left here is actually cave art from Algeria from about 7,000 years ago. With it's kind of a mushroom shaman type of figure. And then on the right are the more well-known mushroom statues from Central America that date back approximately 3,000 years. So that's a long record of use. And then, but we think, okay, Hoffman in 1957, was first isolated psilocybin in the Western medical context. So pretty short period of time compared to the traditional setting. Anyhow, we've been doing there's been quite a bit of work in those 50 years. I'm not going to discuss the first wave of research that happened in the 50s and 60s and focus more on what's happening now. Psilocybin is being looked at in, as Gianni pointed to, quite an array of different mental health conditions, and psychedelics in general are being tested across really a lot of different conditions, but psilocybin specifically studies in anxiety and depression in cancer patients, in OCD, and in various substance use disorders. I have here treatment refractory depression, but also in just general major depressive disorder. And of course, a fair bit of non-clinical research happening with psilocybin, from very basic science, cell biology kind of research, to fancy neuroimaging research, to social psychology research across the board. So really an interdisciplinary field of study, which I think is the strength of psychedelic science and at least what keeps me fascinated by it. So I'm focusing on depression. I'm not going to spend too much time talking about the background studies. Many of you might be familiar with the phase 2 trials of psilocybin therapy in cancer patients that was published in 2016. There was a lot of, those generated a lot of excitement because essentially one dose of psilocybin was shown to produce long-lasting benefits in these patients up to about 6 months out, which is a pretty remarkable finding. And then also in 2016 was Robin Card-Harris and his group at Imperial College published this open label study in treatment refractory depression. It was, again, a small open label study, but again showed fairly good results from pretty promising results in large effect sizes from one single larger dose. There were 2 doses in that study. And Dr. Alan Davis is on the call, and I know he just published a study out of Hopkins in major depression just last week. And I haven't had a chance to review those results, but I encourage everyone to go look at that paper because I'm sure it's quite exciting. The study I'm going to present, I've been working on for about 5 years already, and so it was right in the context of this study, the Card-Harris study being published, which again was open label, and so we were pretty interested in seeing whether we could replicate those results, especially with a placebo condition, and then also to get a little bit at mechanisms of action. Thinking about this question of, well, how does psilocybin work specifically as a treatment for depression? And so the study that we came up with, I'm working primarily in a neurobiology lab, and so it's kind of marrying some interest in the lab's expertise in EEG and neurobiology, mechanism of action research with some of my own interests more in the psychotherapy portion of psychedelic research and kind of putting those two together. And so it's been an interesting study in that regard. So we called it Psilocybin-induced Neuroplasticity in the treatment of major depression, which did reflect that the primary aim of the study is actually an EEG measure of neuroplasticity. And I'll go into that a little bit later in the talk. We were also looking at some other measures like verbal memory and emotion processing with a novel affective go, no go task that was developed also in the lab that I'm working in. So that was cool to work with guys who are so knowledgeable in that area. And then in the context of formulating this therapeutic paradigm using acceptance and commitment therapy, we were also looking at psychological flexibility as a psychological mechanism of action. And again, I'll discuss that a little later in the study. We also had have a qualitative component of the study to further investigate psychological mechanisms of action in a more open-ended manner. We are collecting efficacy data, but again, it's a relatively small study, and so we weren't powered to necessarily to detect statistically significant changes in depressive symptoms, but we're definitely looking at them, and of course, a bunch of safety measures. So just briefly talk about the study design. It's a double-blind, placebo-controlled within subject crossover design study. Our goal is to enroll 18 participants. They have moderate to severe major depression, and in our trial, we've required one or more medication treatment failure. Patients do have to come off of their medications like most psilocybin studies in order to qualify. I'll show the study design a little more on the next slide, but it's basically 2 dosing sessions 4 weeks apart, embedded within 8 therapy sessions. And then there's 4 EEG sessions. And in the 2 dosing sessions, participants receive 2 of 3 dose conditions in a random order, placebo, which is just an inactive placebo, and then low dose psilocybin at 0.1 milligrams per kilogram, and then a medium dose at 0.3 milligrams per kilogram. So the study kind of looks like this. The first 2 lines show essentially how the crossover nature, the first 2 halves sort of mirror each other with the 2 dosing sessions in yellow, followed by EEG sessions 1 day and 2 weeks after the dosing session, with therapy sessions before and after. So you can see that the purple shows just where we're collecting some of the depression scales. And so at this 6-week time point is basically the end of the crossover double-blind portion of the study. And then we do have a more longitudinal component going up to 16 weeks. And actually our qualitative interviews can happen up to 6 months out. So trying to also just collect some longer term data as well. This is the room we've used up until now, though post-COVID we're switching, but pretty typical setup. Our study is actually happening in the West Haven VA, which is pretty cool. There hasn't been, I think we were pretty much the first VA to do any kind of psychedelic research in this modern era, I suppose. And I'm happy to hear that there's work happening at other VAs now, the Bronx VA and potentially some others. So we spruced up a VA office, which was a little challenging, but we did our best. And it's gone pretty well. But typical setup with the couch, music, headphones, 2 therapists sitting across from the patient, some artwork, plants. All right, so where we're at as of now, you know, initially we developed these EEG tasks for the study. I spent quite a while developing this therapy protocol incorporating ACT and published that model in the Journal of Contextual Behavioral Science in January. We also published the manual itself. I'll show you later, but that was also published this year, the full treatment manual, open access, so it's available. We developed a training program for our therapists and trained 5 therapists. And as far as our recruitment, we've enrolled 14, completed. We have only 8 completers, and we've now have 2 subjects in progress at the moment since COVID. And of course, we were shut down completely for the last 7 months up until this past month. So they had too much in the way of safety issues in the study thus far. Luckily, we did have, as I showed you, there were a couple of folks who relapsed, and one did pursue hospitalization and ECT, and so that was considered an SAE, or a serious adverse event. But aside from that, it's really been relatively smooth. No rescue medications have been administered thus far. And an issue we could definitely talk about is at the end is about participants in research studies pursuing underground psilocybin treatment after, which has come up a couple times. So let's see. So we're at 9 o'clock. We've been going for about half an hour. So good. I'm going to transition then and talk about something that is I like to talk about, which is more the therapeutic component of psilocybin-assisted psychotherapy, and then how we combined it with acceptance and commitment therapy. So I think we can think about psychedelics as acting. Uh-oh, sorry guys, I think I just clicked off. Sorry about that. Okay. Gianni, you're seeing the right thing now, right?
Yep, it's perfect.
Okay, great. All right, so we can think about psilocybin as through different, I sometimes like to call it like discourses really, or different mechanisms of action, you know, from it's acting on a neurobiological level to more psychological and emotional levels. Some papers discussing also the social and ecological impacts of psychedelic use, and we can also think about it through spiritual and mystical lenses. And for me, this isn't, it's been a really, interesting journey, having gotten in the field over 6 years and having to navigate these different kind of discourses with different folks. But I really think I've really tried to not pigeonhole ourselves or the study in one particular basket here, although certainly we're, and I think what we're seeing now is certain centers are opening, definitely obviously a pull towards the neurobiology. But for me as a social scientist and an anthropologist, what I'm really interested in is how all these things relate to one another. And I think psychedelic science is unique in that regard, that it really draws together research and such an interdisciplinary approach, and that we can actually, we don't need to be dichotomous about this. We can really start tying together these different ways of knowing, and that's quite exciting to me. And in some ways, it all comes together in the practice of psilocybin-assisted psychotherapy. I'm going to go into, most of you are probably familiar with this term. Essentially, it means that you're embedding the drug sessions within a broader course of psychotherapy. And this is a little different than just pairing it with psychotherapy. It's not like we're just doing, drug sessions like ketamine infusions and then a course of CBT. That would be one, way of putting two things together, a drug treatment and a therapy. But this is really more one package where the therapy revolves around the drug sessions. The drug sessions are considered as having meaning and value. And then you're working with folks before and after to really maximize that. Or in an ideal world, potentially you're just in long-term therapy and then punctuating that long-term therapy with occasional dosing sessions as a way to potentiate that therapeutic process and relationship. Set and setting are cornerstone principles. Sure many of you are aware of them. Basically, set being mindset and setting being more the physical environment piece. Definitely, we recently launched a reading seminar in the Yale Psychedelic Science Group, and we read an awesome paper by Ido Hartgodson. I'm not sure exactly how to pronounce his name. But he recently also just published a book, I think, called American Trip, like a history of set and setting. But the article we read on was really excellent. I'd recommend that for learning more about set and setting beyond sort of the basics. And then we use this essentially this preparation, support, and integration model. That's pretty standard in the field. But I'm going to talk a little bit about what's different in our study, and then just I want to spend just a minute also discussing how this psychedelic therapy model compares to a more psychopharmacological model. And in some ways, I'm hesitant to set up like a straw man argument, because I know, a lot of psychopharm treatment integrates psychotherapy, but I'd like to consider at least the psychopharm model we could think about as IV ketamine infusions versus the way that psilocybin studies have been run. So in more of the IV ketamine or psychopharm model, it's essentially the patient is in a passive position. They're just consuming either the medication or it's being infused into them, and their main job is just to be compliant, show up for the dosing, kick back, and just sort of, don't really mind the quote side effects, but just take in the medication with the hope that it's going to act on the brain as the primary locus of action, whereas in psychedelic therapy, I think we have a more biopsychosocial approach in general, or more holistic approach. In the psychopharm model, we're primarily trying to target signs and symptoms of a given illness. I think this is a bit of a challenge with psychedelic therapy, because in the FDA studies where we are trying to target them for a particular diagnosis or condition, but I don't really think that's really how psychedelic therapy works. Like, we're not necessarily just like trying to target a particular symptom, but we're really looking at underlying causes, patterns, and traumas, is at least how I think about it. And I think the goals are a little different in a psychopharm model. We're really trying to ameliorate that illness, diminish symptoms, improve adaptation to someone's current circumstances. So when we do just ketamine infusions at the VA, we hope that they're doing therapy somewhere else, but it's not really part of what we're doing. Whereas in psychedelic therapy, the outcomes are a little less predetermined, I think. We're open to seeing where things go and what changes people make. But we're generally trying to have patients embrace the full range of experience, change their relationship to their symptoms, and hopefully live a full and meaningful life. So I think you'll see, I'll show on the next slide how this relates to the acceptance and commitment therapy model. I definitely don't have time to get into too much of this because that could be a whole lecture on its own. But briefly, acceptance and commitment therapy, or ACT, as I'll call it, it's a third wave cognitive behavioral therapy. And importantly, the treatment target in ACT is something called psychological flexibility. So it's not a particular diagnosis or a particular symptom. It's this construct of psychological flexibility, which in itself is made up of 6 core processes: acceptance, diffusion, contact with the present moment, self as context, values, and committed action. And I guess they're split up into sort of 3 sections. This is called the hexaflex, sort of the be open side of things, be aware is in the center, and be engaged is kind of the more behavioral component. So this is the more cognitive portion of ACT and the more behavioral component. So it does still have that cognitive and behavioral pieces, but the cognitive part is a lot more rooted in mindfulness as opposed to change per se. And psychological flexibility is a transdiagnostic construct, which I'll get into. And so, we went through a very long process of trying to figure out what therapeutic platform we wanted to bring into the study. We chose ACT because we saw quite a few conceptual overlaps between just our general conception of how psychedelic therapy works. And I'll say this is the work of, this is myself, this is Jeff Gus from New York University, and then my team at Yale, including Robert Krauss and Ryan Wallace, who are both, all of us were instrumental in putting this together. So in the psychedelic models, we expect more of an active engagement in recovery, and in ACT, there's quite a bit of room for that in terms of participants doing mindfulness practices, values clarification, a whole bunch of different exercises, as well as committed actions. Again, we're interested in addressing underlying causes and patterns, and that's very much what ACT is all about in terms of promoting this broader psychological flexibility construct. And it really is focused on changing patients' relationship to their symptoms as opposed to actually going after the symptoms directly. It does have a pretty holistic approach in terms of the hexaflex that I shared on the last screen. This is considered a functional contextual approach. So pretty psychological and behavioral. Definitely in our study, we're also, nice part is we're getting the bio piece in terms of pairing this with psilocybin and understanding its drug actions and trying to take advantage of this hypothesized window of neuroplasticity. So I think we're really trying to build a real biopsychosocial model for psilocybin treatment here. And in terms of this idea, in psychedelic therapy, trust, let go, be open, Bill Richards' famous saying, it's right there in ACT in terms of decreasing so-called experiential avoidance and increasing acceptance. So kind of a perfect fit there. And the outcomes are essentially the same as what I shared before, really about, in ACT, it's really about living a values-driven, meaningful life, which is just their little tweak, focusing on values. So, so another reason that I thought that our team believed that ACT and psilocybin therapy may be synergistic relates to our hypothesis that the actual experience of moderate to high doses of psilocybin with preparatory priming and psychoeducation can provide direct experiential contact with the ACT processes that promote psychological flexibility. And so I'm going to just try to highlight some of those more experiential overlaps beyond the conceptual overlaps that I shared before. And here on the left, you can see the domains of altered states of consciousness. This is like what's in the often called the 11D ASC in the Stru et al. 2011. And then here is the ACT hexaflex with the different ACT processes. So, all right, let's go through a few of these. One important reason that there's overlap here is that, so the experience of unity, spiritual experience, disembodiment, for instance, these can help provide a direct experiential experience of this concept of self as context, which is not always extremely easy for patients to experience. It's more of, can be much more conceptual. So in ACT, this self as context idea is basically refers to like self-transcendence or the observing self. And so when you're doing just straight ACT, there are exercises to help participants understand this as a concept. But I think with psychedelics and with these kind of experiences they engender, you can provide a valuable lived experience of what it's like to have observing consciousness. So that's one really, I think, valuable overlap there. Similarly, the intensity of the psychedelic experience in terms of altered perceptions that you see here on the right, and powerful spiritual experiences are likely to bring people into contact with the present moment in a very powerful way, get them out of their head, assist with the diffusion process, and bring them right into the present moment during that intense experience. Again, as this is happening, I think this is one thing that we've observed, and I'm sure in most psychedelic research, is this process of diffusion, or kind of loosening your attachment to repetitive kind of thoughts, not being so believing that the thoughts that you have reflect reality. So I think the psychedelic experience can help decenter that for people in a very meaningful way, to help them question their perspectives and just get out of those same repetitive ruminative patterns that we see in chronic depression. Next, psychedelics can bring about a range of challenging emotional experiences. As we're aware up here, like anxiety, impaired control, loss of control. And again, through working with participants, and again, I think this is why it can be very different in a therapeutic context versus if these experiences are had outside of a therapeutic context. But with helping patients trust, like go and be open to those experiences, we can really help foster acceptance of difficult emotions, including in the body, as well as just like anxiety, right there in the session in a very powerful way, and then continue to work with people during the integration phase to follow up on those experiences. And then just lastly, I think psychedelic-induced insights, which again is here on the ASC, can very much assist with the process of values clarification, and that's really helpful. A number of our participants come out of the dosing sessions having realizations that they've been neglecting certain areas or relationships, for instance, or they really want to get back into particular practices or behaviors. And then we can work with them again during the integration phase to change those, put those values into committed action. So in summary, given the conceptual overlaps and complements in approach, we hypothesize that by thoughtfully infusing ACT principles into the course of psilocybin therapy, that we can amplify clinical improvements and hopefully lengthen the duration of improvement from depression, with increases in psychological flexibility being a key mediator in that process. I'm not going to, this is just how, if you want to check out our manual, you can see how we actually put ACT into the various sessions in a protocolized kind of fashion. So that that's on PsyArchive, the full manual, or for a more a brief introduction to the model, you could please check out our article in JCBS. We don't, we have only very preliminary data at this point about whether that hypothesis I shared is actually the case, and like how well ACT, does ACT actually work better than just a general support model. I don't have that data at this point. It's been great that we're not the only group who's been working on ACT. There was a whole issue that the article that I mentioned in JCBS was part of a special issue on ACT and psychedelics. This is actually from Dr. Alan Davis's paper that also showed some preliminary data that increases in psychological flexibility do mediate improvements in depression and anxiety in the sample that they were looking at in that study. And then this is in our study where we're just, at this point, I can say that there's somewhat of a trend towards, so AAQ is a measure of psychological flexibility, and lower is better. So there's been a trend throughout the course of the study towards improvement in psychological flexibility. So that's good. And as far as trying to get at, again, I don't know the dosing conditions at this point, but are these mediated by the psilocybin dosing sessions? I could look at, in this case, using mystical experience as a correlate for the higher dose sessions. We do see in this case actually a trend towards greater improvements in psychological flexibility following the higher dose, well, I can't say higher dose, but following sessions that have higher MEQ scores. So I think that looks good for that hypothesis that I was sharing before about the actual experience of the dosing sessions helping promote psychological flexibility. Again, we'll see how the data continues to look. So I want to wrap up and leave lots of time for questions. This research is moving ahead quickly, as I'm sure many of you are following it. Phase 2, there's a couple, psilocybin received FDA breakthrough status for both depression and TRD. Phase 2 and 3 registration trials are underway. We're going to see phase 2 trials for a range of substance use disorders coming out. The completion of the phase 3 trials, MAPS trial, MDMA trials will be soon. We recently saw the Oregon psilocybin bill pass, which we could discuss during the Q&A, which is pretty interesting. Just ongoing training and education of psychedelic researchers and therapists, which is something I'm very interested in. And then I did want to just touch on, lastly, just kind of going into the Q&A, because I think we can have some good discussion here. It's just certainly this summer in particular, and just in general, I think, given my background, but you can't ignore this if you're in the field, how politics interfaces with science. It's just all over psychedelic science. And so really this summer, we had a series at YPSG really thinking about this question of how does white supremacy function within psychedelic science, and continuing to think critically about that question. And I think it's all the more so relevant as we're facing commercialization of psychedelic therapies and scale up with huge amounts of venture capital coming into the space. We're really at a time when we need to, as a field, think about what are the treatment models we want to put out there? How is this going to actually, it's one thing, it's been in academic circles, but now as it's really going into the world, what is this going to look like, and where are benefits going to accrue? Who will be the beneficiaries of these treatments? Who will be making the money from the scale up of these treatments? Is this going to be equitable, both in terms of the patients that it reaches and the therapists who are providing it, and the people funding it, and the people making money off of it? So definitely want to be thinking more about that. And at least for me, I'm interested in thinking about how psychedelic science can be a force for social justice. And in particular, I think we need to think more about issues of diversity, equity, and inclusion. Been really happy this last couple months to be starting to work on a nonprofit initiative focused on this area. we're not like launched as of yet, but we're calling it the Equity in Psychedelic Therapy Initiative, EPTI. Hope to be doing some really good work in that space in the coming years. So yeah, that's a lot. Obviously, in this last question, we could talk about drug policy with the Oregon bill and increasing decriminalization bills happening across the country. Super interesting what's happening in this world right now. So I'm going to close there, and we will go to questions. I'm just going to acknowledge all the folks who've contributed to the work that I've been doing and just presented, the PI of the study, Dr. Cyril D'Souza, Dr. Skosnik and Cortez Briones and Sharif, who designed all of those EEG tasks and analyzing all that data, the entire lab that we're working in, the Synergy Lab, and the research assistants have just been incredible. Dr. Wallace and Gus for their work on the manual, as well as Robert Krause, who's also been our lead therapist. We've had just a really wonderful team of therapists working on the study, and our funders at Hefter Research Institute and Carrie Turnbull in particular, and to the study participants who are teaching me a lot, and I owe them a lot for their dedication and persistence in the study. So thank you, and feel free to reach out to me, check out the Yale Psychedelic Science Group. These days, everything is pretty much on Zoom, so it doesn't matter where you are. You could sign up for our mailing list and join us for some of our webinars. And let's take some questions.
Thanks so much, Jordan. So I guess we can do this, just my voice can be like a little ghost voice. We'll look at you, but you can hear me talk. A bunch of, so I guess since I feel like the overlap between acceptance and commitment therapy and the psychedelic therapy, the tenets of each are, they so nicely overlap. And I just want to highlight one thing you said, which was that this idea that based on these qualitative reports, so participants in these studies, they may report that this experience changes their relationship to their symptoms. So even if the symptoms aren't necessarily changing in severity, that the relationship to them does change. And I think that maybe one thing that traditional psychometrics of psychiatry misses. So you might call a treatment a failed treatment if the depression score doesn't change, even if a person, say, is relating to it more mindfully or with more acceptance or with any of these other acceptance and commitment therapy ideas.
Yeah, no, definitely. And I think that's why it's important. I didn't show all the secondary measures that we're collecting, but I think it's important to look beyond, especially given that that's the model we're working in, to look beyond just the change in HAM-D, even though that's, you know, what the FDA is interested in. That's what a lot of scientists and clinicians are going to be interested in. But I think we need to look at, you know, and that's why I'm trying to look at psychological flexibility, et cetera, mindfulness, and quality of life measures as well to see, because, and I wouldn't say necessarily patients are reporting that their relationships are different, but that's the paradigm that the therapists are working in, and working with people in that way, that we're, you know, we're not judging it negatively as soon as a patient has, you know, a recurrent negative thought after their dosing session. It's like, can we just relate to that differently than before? It's not that it needs to all of a sudden, you know, that psilocybin is going to make those thoughts never come back. I think that's a little bit of magical thinking. It's more, can we now diffuse a little bit more from that more quickly in the name of those valued actions, at least is how the ACT model would work. So it's just, those symptoms can be there, but can they not prevent you from being the person that you want to be in the world and acting in a valued, engaging in your valued actions. So yeah, that's really what we're working with people towards, building out their life. And if the symptoms are still there, all right, I mean, we'll keep working on that and see. But so I think that's the way, at least we've been approaching it. And I think we'll see how well that works. But I think it makes intuitive sense with psychedelic therapy in general as, you know, sometimes I just like to say, like, I mean, mushrooms weren't put on the earth, and like psilocybin didn't come on to the earth specifically to treat a disorder created in the DSM-5. You know, it's like they're doing, you know, they're going to do different things for different people, and we're kind of artificially putting over these constructs in the DSM and seeing, well, does it work for that thing? Well, maybe partially, but it's going to also do some other things.
Right, right. Yeah, imagine if it had. You pick a species of mushroom for like, that's the MDD mushroom over there.
Strain.
Yeah. There's a ton of great questions that I do want to have you speak to. One is from Ryan, who's actually one of a resident here, who's I don't know if this is fair to say, but an expert. Is that fair to say, Ryan, on EEG, and actually very curious about, I think has done some work on synaptic plasticity and is very interested about ACT. But so, Ryan, I can unmute you, but I'll first ask your question is, what are some ways that you know of, Jordan, to measure psychological flexibility that don't depend on a person's subjective report or self-awareness? So anything you can see from the outside or objectively?
Yeah, it's a good question. I think this is one area that the ACT community is still working on, is developing really good measures. I think there's so as far as the actual more subjective measures, like we're using this one called the AAQ. That's one. There's also measures of experiential avoidance in particular. That's kind of one of the core parts of psychological inflexibility. So again, those are more the subjective measures. As far as objective measures, I think, you know, there's a difference between cognitive flexibility and psychological flexibility. At least the way, you know, psychological flexibility, the way I'm using it, comes directly out of ACT. So it's based in that therapy, and I'm not aware of any specific objective measures for, quote, psychological flexibility. I think one question that I'm interested in looking at in our study, I mentioned at the beginning that we have an affective go, no go task to look at emotion processing, and that's like a cognitive flexibility task that has objective measures depending on how patients perform on this go, no go task. So we're going to have that data, and I'm going to be very interested to see if that correlates with the psychological flexibility data. So do changes in this kind of psychological, in a cognitive flexibility EEG measure correlate with the more ACT-based psychological flexibility measures? So that's kind of an open question. Maybe if there's other folks who know of objective measures for ACT, I'd be interested, but I'm not aware of any.
Sure. Yeah, there's a ton of really great questions. One I want to highlight, because I think it's something that you in particular have thought about a lot. It was put in the chat, is given the regulatory trajectory of psilocybin and other psychedelics, how do you recommend early psychiatric or other mental health trainees get practical experience and prepare to incorporate these therapies into their future clinical practice?
How do they get practical experience? It's
how do you can interpret that how, I mean, yeah, practical experience.
Yeah, it's been a huge challenge actually, and I'm still not sure what the best answer is. I've been sad over the years to have so many people like reach out and ask for ways to get involved, and it's not easy, at least in these clinical trials. I mean, and we do spend a lot of time training our therapists, so it's not really easy to have trainees just come in and really be part of those dosing sessions, and they're so intimate that we really don't allow folks to kind of observe or pop in. So I think that is challenging. I think what I've recommended, is that people who are interested start, get involved in a psychedelic science group, start reading all the articles. There's ever more like awesome training material that's being developed and folks who are doing trainings across the country. I think there's different ways to sort of approximate the experience. Ketamine therapy is legal, and you might be able to find a ketamine practitioner who you could work with locally is in an apprentice kind of role. Holotropic breath work is something that people can do if you want to practice sitting for someone and being sat for and going into an altered state of consciousness. I think that's a good way to do it as well. And I mean, certainly, there's going to be more opportunities as more studies get off the ground, and certainly as the therapies become more approved and legalized. So I just encourage folks to follow their interest and just see what opportunities there are available. But certainly it may start, you may not be able to get into a dosing session for a while, potentially.
Yeah, I would have said the same thing. And I think maybe following from your work, in like what you can certainly get training in the practical application of ACT, for instance, or any of the therapies that are now being proposed to add on to or use as the frame for this work, especially the ones, as you mentioned, that are particularly well matched for it. So I think that would be good preparation. That's what I'm trying to do.
Definitely.
In my training. It looks like there's a few questions about the specifics of your study. And I think this is just a point of clarification, but what did you use as your placebo?
The placebo is just an inactive sugar pill. Yeah, so our approach with blinding, blinding is such a tricky issue in all these studies. What we decided on for better or worse was to have this kind of paradigm where rather than using like an active placebo like niacin, which is done in some other studies, which, I mean, maybe it's a little bit better than a sugar pill, but really we wanted to play around with expectation. And unfortunately, we're not measuring expectation as well as we should have been. But the idea was that by having 2 dosing sessions and 3 dosing conditions, that we introduce uncertainty into the model, and so participants don't know what they're going to be getting. Whereas, like in some of the cancer crossover studies, it was either just placebo or dose. And so if you got the placebo, you were pretty sure what you were going to get. The blind was broken. So our approach was to introduce a little more uncertainty so that the blind wouldn't necessarily be broken at any point in the study. So obvious. And with that low dose condition, can be hard for patients to know if they got the placebo or was that the low dose. So, I don't know what I'm going to get the next time. So I think that was our hope. We are collecting a little bit of, we're asking participants after the dosing sessions what they think they got. I don't know. I think we'll see how well the blinding works. It's tricky, but that was how we did it in this study. Yeah,
and then I guess you also have to ask you and the other therapist what you thought too, to see if you could guess.
We should. We actually haven't been doing that, which is probably a flaw.
A couple questions about the mystical experience and the questionnaire. I think a person asked, how do you measure it? I can just speak to that. Or how do you calculate it? There's the standardized questionnaire, I think, that was developed, out of Hopkins, took into account a bunch of things, but it made it into a standardized questionnaire that the participants fill out, and then they get a score, and there's a threshold above which is the complete mystical experience, below which is a quote unquote partial experience. I'll let you add to that, Jordan, if you want. But the second part real quick is, you showed a graph that showed an imperfect, if any, correlation between that and I think decrease in symptoms, or I'm not exactly sure what outcome it was paired with, but regardless, it was imperfect, which is to say that there are plenty of psilocybin sessions, high dose psilocybin sessions or we suspect that are for whom people are not having mystical experiences. The question is, what does that look like? And maybe you can speak to a little bit about how you understand mystical experience in the context of these sessions.
Yeah, so the first part, so we do look at mystical experience, its subjective ratings. We use both the MEQ30 and the 11D ASC scale, so we collect both of those. There's a number of other ones like Hood Mysticism scale. There's a bunch, but I think the two that we're using are two of the more commonly used ones. Yeah, I mean, I can't say as far as, again, I'm blinded, so I don't know like what. It's hard to sort of answer the question as far as like what is it. I don't know who's on which condition. I think, but certainly yes, there's going to be variability in what these sessions look like for people. I think I've seen everything from very clear, like people really in like a beautiful, like kind of mystical kind of state connecting with spirituality in some kind of way, or really being just completely in a whole different state of consciousness, to patients who, and it changes throughout the course of that session. It's just so variable. But I was going to say some participants who remained more in dialogue during their session, and if I had to guess, it seemed like they were on the drug. And some, I've had one participant who laid there practically silent almost the whole, for the first 4 hours straight. And then there was participants who really wanted to remain in communication with us a little bit more. And I wonder if that has anything to do with trauma history. I think it may potentially, but it may also have to do with just comfort with really fully letting go, or just what that person needs to work on in a particular time. And I could share like a funny little anecdote about that. In the studies, we try to run all the sessions, in a similar way. We start, the patient takes the capsule, they have their music going, and usually after, 10, 15 minutes of chatting, we'll encourage people to have like a more inner directed kind of experience, lay back. And like that's, to try to maintain some consistency across the dosing sessions. That's kind of the suggestion is, and even if at some point patients will want to come out and talk to us for a while, after a little bit of time, we might suggest again, okay, maybe now it's time to go back, and would you like to put on your headphones again and go back inside for a while? And there was one participant who just really was like, talking, and eventually after maybe, a good while of talking, I tried to make that suggestion, and the participant just basically told me to go F myself. like she's like, this is my session. I'm gonna I want to talk. She's like, I've never said, but and it was great because for one thing, she felt safe enough to actually express that, and she wasn't like necessarily someone who that was a real like breakthrough in being able to establish her boundaries and assert herself in that way.
I hope you publish that in the qualitative literature.
It was good. And and she was, because she said, like these were all things she'd never expressed to anyone, and like it was really like therapeutic for her to just allow that to like get off of her chest. So just to say, the conventional wisdom is never right in all cases. These sessions are good. I've definitely been surprised almost every dosing session. I do not assume ever that I know what is going to happen in a session, because they've all, and I've only run 8. I've been in about 20 dosing sessions so far. They've all been different. So
cool. One last question to tack onto the mystical experience topic, and then I want to address a few about acceptance and commitment therapy. But last one is someone's wondering if you measured or assessed people's spiritual or religious beliefs or attitudes at baseline, and then saw if that was correlated with the mystical experience score that they reported.
That is a very good, astute question and point. The answer is no, we didn't. Should you? Probably be, if you're like wanting to really look at like mystical experience as a key variable, I think it would probably be a good idea to do so. but we didn't do that in our study.
Cool. Okay, so yeah, a bunch of questions about acceptance and commitment there. And Jordan, just let me know when you got to run. Otherwise, I'll try to.
Oh, I'm good.
Okay, cool. So Wendy is wondering, she's amazed that you were able to train 5 therapists in 4 days. And she's curious what qualifications or experience you looked for when you were recruiting these therapists who you trained, particularly experience with ACT or any other experience with ACT or psychedelic assisted therapy or other qualities.
Yeah, it's a really good question. And this, it kind of relates to like a thought I had related to the other question about like getting practical experience. And like, I would really recommend to people who, I mean, again, it depends. Do you want to be a researcher? Do you want to be a therapist, like a psychedelic therapist, et cetera? But become a really good clinician first. You know, that was like the thought I had at the end too, like about how do you get good practical experience? It's like, get experience working with patients, you know, and like sitting with patients through like difficult, you know, sitting with patients and just being with them for a while during like difficult experience. And like, you know, that is extremely valuable. And so that the reason I mentioned that is I think we looked for clinicians who were experienced in working with patients with major depressive disorder, longtime clinicians who, again, had, we did not require actually experience with ACT nor with psychedelic therapy or training, but we did require them to be licensed therapists with significant clinical experience and have worked with depression. And then we definitely favored, and pretty much everyone that we recruited had experience with like related modalities. So with either some degree of mindfulness background or using mindfulness in psychotherapy, or at least having some familiarity with CBT principles, which, you know, ACT is different, but if you have some framework of understanding what CBT is all about, you can kind of get what ACT's about. So we kind of looked for those kind of qualities, and then just therapists who were really, these were all folks who were really passionate about learning about psychedelic, like they wanted to be doing this. And so we knew that they were going to be continuing their own education. But we spent in particular with the help of Jeff Gus, who was just such a wonderful mentor through all of this. We designed a 4-day training where we went over, you know, basics of psychedelic therapy and sitting, as well as acceptance and commitment therapy. We actually had an ACT trainer come and do a day with us, which is not a lot of time. And again, you know, this would be very different if we were a psychotherapy study where we were actually like really, you know, standardizing the therapy and to like with adherence ratings, which we weren't doing that degree. I mean, we did have this protocol, which I think not only do I like it conceptually, but I think it led to our study being more scientifically sound, because as opposed to just leaving it to therapists to do whatever they want, which is going to be variable based to the therapist, we actually were providing a framework for all therapists to use, but while maintaining the flexibility that ACT allows for, which is for you to make a formulation of your patient based on the ACT principles and work with them however you want, but you're sort of working, well, not however you want, but formulating the patient according to ACT principles and then choosing which points on that hexaflex you want to work on more. So the way it looked for every patient was different, but there was a sort of a common structure.
Yeah, that I love that answer, and I think that also agree that addresses that earlier question. So it sounds like, you know, because it's tough to get in. There aren't many opportunities available to trainees to work, or any clinician to work directly with patients experiencing or receiving psychedelic treatment. But like you said, I mean, you know, essentially a passion for it, a curiosity, being licensed, and then experience both with the condition, but also a related modality like mindfulness or ACT. And it's also, I think, your study and just both from your report, but also the results, may be a testament to, does this work? So can you have people who aren't, trained or experienced in psychedelic therapy or ACT, then be trained and administer it with good results? My super quick question I would insert is, you talked about how then these therapists were able to integrate ACT into the way they were administering the therapy. I'm curious if the patients or the participants themselves began to adopt the language of acceptance and commitment therapy in their narratives and then after the treatment sessions, or if they maybe went back to how they were formulating it before.
So it's a good question. There's a couple things. I mean, as far as that, we did do like psychoeducation with people about the ACT principles. So they definitely had developed we thought, and it's not necessarily part of I don't know that all ACT therapists actually teach their patients like the principles of ACT in a didactic kind of way. We did a little bit. We did psychoeducation because I thought it would be helpful for patients to have a bit of the language, and also to, part of what we were hoping was that patients might register their experience through those terms, like both in the dosing session and then afterwards, and that we could work. But that was kind of variable. I don't know how much they continued to use the language. That's something we will look at in the qualitative, not just in general, how patients enjoyed the therapeutic modality and what aspects of it they found most helpful. So hopefully I'll have a little more answer to that later on when you have me back in a year when I've finished the study. But as far as the other piece too, just about training, and this gets to the Oregon initiative, that's really interesting. But it's something that I think is an important distinction. So in this new Oregon bill that passed just on election day to legalize psilocybin therapy, the providers of psilocybin therapy will not have to be licensed clinicians. I'm sure many of them will be, but it's not going to be required. And there's going to be a 2-year period where they're consulting and figuring out the specifics of this. But you're not going to have to be a licensed clinician. And I think that that's fine. I just think it's a distinction that I make, and I sort of pointed to this earlier, is that I do think there is a difference when you're working with patients like the ones in this study who are in the moderate to severe kind of range and who've been struggling for many years with a particular diagnosable kind of condition. So, there may be a future where you don't need to be a licensed clinician who, all the things that we just said, and to be able to do this kind of work. That just may be with, the folks in the general population, folks with more mild kind of issues who don't require this level of kind of training and intensity of psychological work. But my personal feeling, and we'll see, is that for this kind of population, moderate to severe, chronic kind of illness, I think having the training and having a modality like this, I think is going to be more helpful in those cases, because I think the medicine alone can, while certainly I don't want to rule out the possibilities of miracles and breakthroughs, what I've seen so far is those things do happen, but those symptoms still are there. They still come back in some way, shape, or form, and you need to have a way to contextualize that and to help people continue to move through that and not just get stuck quickly back, but and actually realize how much that they've gained through the process of doing the work that they did in the study.
Yeah, I mean, I think that speaks to the idea of, one size doesn't fit all. That, despite the fact that there's this transdiagnostic effect, it's not just that you can give psilocybin therapy in some standardized way and for patients with people with all kinds of different things going on and different severities. So yeah, I agree. just tacking onto that on the topic of the bill that just passed in Oregon, Larissa is asking if there's a way, or if you have any ideas about protecting people who will get licensed to treat in the medical model, for instance, in Oregon, if they also continue to facilitate journeys in the underground or in unapproved or unregulated settings in the spirit of harm reduction.
Can you say the question again?
I think the idea, and Larissa, please, if you're still there, please correct me in the chat if I'm wrong here. I think the idea is for let's say in Oregon, for therapists who become licensed to administer psilocybin therapy, if those therapists are also providing psilocybin therapy or therapy in some underground way with any agent, do you have any ideas about the relationship between provision of therapy above ground versus below? And yeah, again, please correct me if I messed up that question.
I mean, Oregon did two things actually, which I think are really both critical and important and work together. So on the one hand, they decriminalized small amounts of all drugs, which like is so great. I'm a big proponent of drug decriminalization, and I think that should happen everywhere. And they did this thing that legalizes sort of supervised psilocybin therapy. And again, actually, you don't, the providers won't need to be licensed, and the people who go to that will actually, you don't need to have a diagnosis to go. So it sounds like anyone will actually be able to go. So they're creating a legal, so I don't think it's going to be like that therapists will be, both above ground and protected. So in the so-called underground, and there is like I think there's a big gray zone in terms of if you are in a decrim state and then you're a therapist working in that, if you're working underground but it's decriminalized, I still don't think that puts you in a very safe position, at least as a licensed professional. But that's why somewhere like Oregon is creating a legal framework that's not very restrictive, so that there shouldn't be a reason to work underground. If you want, if patients want actually the experience of supervised psilocybin, they come and get it. If they want to do their own thing with it, they can go do that, and it's decriminalized, and that's fine. But it's just a different thing. Yeah.
Yeah. I want to make sure I address some of the questions. So maybe can zip through a few of these. One question is are you aware of any studies in which ACT was used as an adjunct to, say, ketamine therapy?
I'm not, but if whoever's asking that wants to do the study, that would be great. I've really wanted, and I know a number of people have thought about this, that wanting to compare ketamine therapy in the medical model versus like a ketamine-assisted therapy model. And there are many practitioners out there who are doing all kinds of different things with ketamine now, but as far as I'm aware, the only like kind of therapy study was actually out of Yale. The author was Wilkinson, but it really was it was what I said earlier. It was like they gave IV ketamine and they did CBT, but the two were they weren't related. It's just one arm got both and the other just got ketamine. And they did show a good synergistic effect. It would be but the question of really doing it in this ketamine-assisted therapy way, I'm not familiar with any studies that have been done. I think when I've thought about doing it, I've been interested in doing a similar thing with psilocybin, to follow up on the study I'm doing. The logical question would be to compare, my ACT model with psilocybin versus like just a support kind of model or a more stripped down model. And I've looked into that. It's just assuming that the psilocybin support model would still be like relatively effective, to try to power a study like that to show a statistically significant difference would require a large sample size and a lot of funding. And so the feasibility of doing that type of study is not great.
Yeah. And I remember there's the don't know if you mentioned these exactly, but the Elias Dakwar studies, I think at Columbia, where they use ketamine infusion and then they have a mindfulness-based therapy interspaced, but not at the same time. Although I think it is a mindful space, it's not the administration of that therapy in the moment.
Yeah,
as
I
an
would
example.
look at Dakwar's work is definitely the best as far as integrating therapy and ketamine. And I'm not sure if any of his studies have like looked at, compared those who did get therapy versus those who didn't. But I know some of his studies have incorporated more of a therapeutic component than, say, a lot of the Yale studies that were much more in the just IV medical model.
Yeah. Okay, we want to zip through a few more. Maybe just give me like a 5-minute warning, or I'll give myself a 5-minute. I don't want to put you in that position.
All right, let's go. Let's do 5 more
5
minutes.
minutes. Okay, perfect. I keep forgetting it's 10 p.m. where you are, so I haven't even eaten dinner yet, so it's early for me. Okay. And yes, I will put the Columbia studies in there. So you mentioned both your the importance of increasing diversity in participants and across the board in this work. What barriers did you encounter in recruiting participants of diverse backgrounds in the study, and then in your nonprofit, what strategies are you using to increase access? And then I'll just pin that, and then if we could save time for just a couple more let's say one more question about neuroplasticity, but feel free to take your time with this one.
Yeah, this is a big one. So as far as like recruitment, I think and this is something like I think the researchers should be thinking about. So the way I've explained it is that we've used a very like passive recruitment approach in our study, meaning, I mean, psychedelics is so hot right now. We get so many inquiries for the study, and we do no advertising. It's just being listed on clinicaltrials.gov as a psilocybin study. With Michael Pollan's book, then 60 Minutes, then all the press that it gets, we just get tons of inquiries. So we're always just kind of trying to tread water, and we're just responding based on who emails us. So. And I do think, that certainly the appeal is diversifying, and there's probably more diverse participants making those inquiries than in the past. But I think it's still, if you're going to use this passive approach, I still think you're going to get that 70-80% are going to be the Caucasian middle upper class folks who are interested in this. So I think that's the pitfall of doing just that passive approach. You're just getting whoever is emailing you. It's going to be representative of historically, it's just been, and there was a paper recently that came out from I believe Monica Williams' group that showed, it's looking across psychedelic studies, 83% Caucasian from pretty much all the work that's been published recently. So I think that's kind of what you're going to get. And so then the question is, what kind of community outreach and how much can an individual study do versus how much does the whole movement need to do versus how much do we need to do on a public policy level to address drug criminalization, which has disproportionately affect communities of color who therefore are more skeptical about drug use, and in addition to all the historical abuses in research, including in psychedelic research, that were experienced by communities of color. So there's just barriers at so many different levels. And so the question, is how much can I do as an individual investigator to say, take a more active approach and do community outreach and make sure that I'm actually posting and doing some amount of advertising in places that might have a better chance of recruiting a more diverse population, is on the one hand. But I think that's limited. So, I think a lot of organizations in the psychedelic space have become more and more aware of this, the historical whiteness of psychedelic research, and have taken on different pieces of this, whether it's, integrating, like Chacruna is one of my favorite organizations that does a ton of seminars and conferences, and they're have done a great job of having a variety of really explicitly trying to get Indigenous voices heard, Black voices heard in the movement, and then MAPS doing some amount of training specifically for therapists of color, and then we're starting this nonprofit to kind of be an organizational home for some of those efforts, not only for, say, fundraising to help patients of color to get into treatment and to get more therapists from, and this isn't just along race lines, but really we're looking at folks from historically marginalized or oppressed backgrounds who are underrepresented in psychedelic research. So there's a fundraising piece, but also what we're, the other barrier that we're trying to address is this idea of culturally attuned psychedelic care. So it's not really, there's an access problem in psychedelic therapy right now because of legal barriers and cost barriers. And those exist kind of across the board. But one of the questions that we're thinking about is access to what? What do we want people to have access to? Do we want them just to have access to, I mean, sure, we want them to have access to psilocybin therapy, but is the psilocybin therapy that, or MDMA therapy that is going to be, on the market, so to say, safe and effective and culturally attuned for all people in society, or is it really more developed and tested in this 83% Caucasian middle upper class population? What considerations need to be taken to provide these therapies to a more diverse population? And so that, I don't have the answers to that, but that's what some of our group is interested in looking at, and even hopefully doing some research on. Yes, in this case, we integrated ACT with psilocybin therapy, but what were we missing in terms of cultural attunement? What pieces might need to be built in, taken away, modified? So doing a lot more like community outreach and engagement and collaborative process with diverse therapists to come up with these models. And we're just in a really early stage, so it's really just taking shape in terms of what people see as pressing in the field, and just bringing together a diverse team of passionate folks who want to work in this space and create something beautiful out of it. So we will see, but there's a lot of work to be done for sure.
Yeah, and keep me posted as when there's a name and a face or a website for it. We'll put it on our website and promote it. Your nonprofit, I mean.
Yeah, definitely. And in the meantime, there's a number of organizations working in the space. Chacruna has some good events coming up. You can always check chacruna.net.
Yeah, so actually, instead of stretching this any further, I'd just say that if anyone has any, I know I unfortunately wasn't able to ask all the questions, so if there are more questions, feel free to send them to me and I can do my best based on what I know about the talk and Jordan's study and my own knowledge. But so feel free to email me and I can do my best. And I'll just leave it to you, Jordan, if you wanted to make any last comments about where you think the field is or your particular study or neuroplasticity. I'll leave it to you to give your 60-second goodbye, or as many seconds as you'd like.
Well, I actually think the note that we just finished on is kind of appropriate, and I think that's probably where I would be happy to leave it. Is really, as I said, beyond being scientists, I think we need to be aware of the ways in which politics interacts with the science that we're doing. I think it affects all areas of science. I mean, just look at what's happening with COVID. But in psychedelics, I don't think you can escape the both political implications, but also the way that politics shapes our research. And for those who want to get in the field, it's like, what question do we actually want to ask? That is really important. How are we going to ask it? And like, what's the framing? So I guess I've seen that as I'm moving through my career, just really taking a little more time to think critically, not just like, well, what would science what's like the next scientific step, but as an investigator, what really excites you and what question would you be excited to ask? Because this research isn't easy and it takes a long time. And then to just pause and think a little bit about the broader implications of asking a given question, and why is that question important? So it's a wonderful field. I think it's just so exciting to be in it right now. There's, I think, a lot of good that will come. I'm hoping I think there's some potential pitfalls that we're going to need to collectively navigate as a field. But we need people who are dedicated to navigate those. So looking forward to Stanford producing the next being part of the next generation of researchers and therapists. And congrats on starting this interest group. Happy to be a supporter of it, and good luck moving forward with it.
Thanks so much, Jordan. And yeah, thanks everyone for joining us, and stay tuned. We'll send out information about future Stanford Psychedelic Science Group events. And I hope we have Jordan. I hope we have you back on in a year or less to give us some updates.
Be great.
Great. Thanks, everybody.